Hi, I'm Joe Roth. At New Jersey Sharing Network, we're committed to saving and enhancing people's lives through organ and tissue donation and informing people about our life-saving mission. That's why we're proud to support programming produced by the Caucus Educational Corporation and their partners in public television.
Funding for this edition of Think Tank with Steve Adubato has been provided by New Jersey Sharing Network, dedicated to saving lives through organ and tissue donation. NJM Insurance Group, the Russell Berry Foundation, Johnson & Johnson, the Healthcare Foundation of New Jersey, founded by the Jewish community, New Jersey Resources, and by Kessler Foundation, changing the lives of people with disabilities. Promotional support provided by Tap Into TV and by AM 970 The Answer.
Welcome to Think Tank. I'm Steve Adubato. We're coming to you from the Agnes Varis NJTV studio in New York. It is our honor and pleasure to introduce Mike Maron, who is President and CEO, Holy Name Medical Center. Good to see you, Mike.
Good to see you, Steve. Thanks for having me.
It's our pleasure. It's part of this entire program is on the future of healthcare. We actually started a conversation with Mike, I don't know, many months back. Yeah. Affordability, accessibility, medical education. Let's go through it. Here we go.
Okay.
By the way, there's a panel discussion right after this. Make sure you stay tuned. Where is New Jersey and where is the nation when it comes to the question of affordability in healthcare?
Well, affordability is a big debate. We're in a transformational stage from an old fee-for-service type medicine to something different. No one is really quite sure what that something different is going to be. We've seen recently with the presidential campaigns heating up a national dialogue around Medicare for all or universal health coverage.
By the way, stay on that. Mm-hmm. When you hear Medicare for all,
yes.
You think?
Bad. Very bad.
Make the case.
Well, you need to have so a couple of things. First off, the case has already been made. If you want to look at it, just look at the Veterans Administration system, right? All run by the government for many, many years. An absolute disaster. Very expensive, very bloated. Veterans can't get access. They don't get timely care. So what went wrong? We're just going to replicate that if we keep pushing at Medicare for all. The system works. Medicare is one of the worst payers in the overall system.
Meaning?
Meaning they pay less than cost. They pay on a methodology that is now 2 decades old and has never been updated.
What are the implications of that for healthcare organizations?
Well, the implication is that healthcare organizations will have to make money to survive someplace else. And as you get with the aging baby boomers and more people on Medicare, that's someplace else.
Where's the else, Mike?
Well, it's commercial payers. It's people like you and I who are still working and getting insurance, and our children.
But our employers are paying.
Our employers are paying. That's right. That's right.
So you don't jump up and down and go, hey, great, Medicare for all. It sounds great, but the economics more complicated?
Much more complicated.
Okay.
Much more complicated.
By the way, I should have disclosed this early on. Holy Name has been a long-time supporter of what we do in public broadcasting at the Caucus Educational Corporation. Mike, let me ask you this. What is the connection between affordability and accessibility?
So it's twofold, right? Some people combine them, and in this whole dialogue, in this debate, everybody...
Do you see it the same?
No, they are different. They are, so affordability means how's it actually paid for? And to me, is the pricing fair? There are people who say it should be free. Well, I can tell you free does not work and nothing is free. Someone's paying for it at some point. And I found this even in our hospital in Haiti, the poorest country in the Western Hemisphere. If people don't have skin in the game and they don't take some responsibility for their own health care, then you got a disaster. So if they think everything is free, then they will abuse themselves and then rely on the system to sort of patch them up and send them back out again and keep coming back. So the individual does have to have skin in the game. There's no doubt about it.
Mike, do this real quick, because you mentioned Haiti. You have to do this.
Yeah.
30 seconds on the connection. We've talked about it many times in the past. Go ahead.
So we took over a 200-bed hospital in northern Haiti in a small town called Milo, just outside of Cap-Haïtien. It's the only private, only successful hospital in all of northern Haiti. Treats about 2.5 million people. Has an average daily census of about 150% of the 200 beds that we have. And it's a very viable partnership between many U.S. volunteers that come from throughout the country and our Haitian physicians and our Haitian colleagues who we train and try to create a sustainable model.
How many trips to Haiti?
Oh, I go about 6 to 8 times a year.
That's what I thought. Mike, do this. If I were to ask you about the whole question of technology,
yes,
and how technology is changing the delivery of healthcare,
yep,
and I think telemedicine right away.
Yep.
Is that's not the totality of it?
No. Oh God, no.
What is telemedicine?
Telemedicine is now the ability to use video conferencing, high-end video conferencing.
Between whom?
Between you, the patient, and their doctor, or their caregiver. It could be a physician. It could be a nurse practitioner.
So say I reach out for my physician, right? And I'm showing him or her a bruise on my arm or a rash or something.
Right.
And they prescribe based on that?
Yeah. They can diagnose over that. They can prescribe and just e-prescribe in medications for you. Saves you the doctor visit, saves them. It's much more efficient. It can be much more accurate.
What about quality?
Quality is good because think about it. This is accessibility. If I can't get in to see my doctor.
What do you mean you can't get in? Because it takes a little while sometimes to see a doctor?
Yeah, because of there's a shortage of doctors, and the doctors are working harder than ever. And we have totally demonized the privacy and the intimacy of a patient-physician relationship over the course of the years in pursuit of business goals as opposed to personal health goals. And so doctors just don't have the time.
You think doctors are being demonized?
Absolutely.
What would be we count on our physicians. Yeah. We count on them being there, and then you say we're you're saying we're demonizing them.
Oh, I am horrified.
Intentionally?
No, I don't think it's intentionally.
Go ahead.
And all these things get defined on the parameters. I think it is by far. Let me just start by saying I am an advocate for every doctor that I have ever met. I think it is the noblest of all professions. I had actually wanted to be a doctor at one point in my life. It's how I got into this business. So I have the highest regard and the highest respect for these men and women who commit their lives to caring for somebody else. It is just a phenomenal calling. And the good doctors are just even that much more so. But what's happened is the economics of healthcare have not allowed physicians to actually practice their trade in the most effective way. They're not allowed. There's time. They will not pay for that personalization of a relationship between you and your private physician so they can know everything about you.
So where's the incentive? Well, I'm not saying the incentive should be just making money.
Right.
But there's a disincentive to spending more time with patients?
Yeah. Well, because the doctors today only get paid based on that time. They got to churn and they got to see. If they're not seeing 20 patients a day, they're not breaking even.
Mike, is that we're talking with Mike Maron, if you're listening to us on the audio side, President and CEO, Holy Name Medical Center. This is part of a think tank program focusing on the future of healthcare. There's a panel discussion actually that includes the Commissioner of Health in New Jersey on this. But it's not just New Jersey. I'm curious. New Jersey healthcare culture and environment dramatically different than the rest of the country? If so, how?
A little bit different in that, well, we have a different payer mix. So Horizon Blue Cross is by far the dominant payer in New Jersey. That's a unique phenomenon to New Jersey. And we've had consolidation in New Jersey that is atypical in the rest of the country. So there are now 3 large systems that dominate the provider side of the landscape, 1 large payer that dominates the payer side of the landscape.
That's atypical.
That's atypical.
Okay, how about this? Go back to the physicians. Medical education.
Yes.
What do you think needs to be done to improve medical education, A, and B, why are we losing so many terrific physicians to other parts of the country?
Okay, so twofold. One, because of what we've done to demonize doctors, there's been a brain drain. The best and the brightest no longer really want to go into medicine. From undergraduate into medical school. They can make more money and they can have a better lifestyle if they pursue other careers.
But isn't New Jersey losing physicians? So they're still staying physicians.
Correct. So New Jersey is training doctors and they're all leaving the state because to start practice in New Jersey.
Where? North Carolina, Georgia,
Texas, Florida.
What are they doing that we're not doing?
Well, they have lower cost of living, lower practice costs. So malpractice costs are significantly lower in Texas than they are in New Jersey. And they'll do loan forgiveness on medical education.
There's different schedules. I heard the quality of life. I don't listen. We're not advocating that you leave, but
no,
I heard
we need them here. Yeah.
All right. Go back to medical education. A minute left. What changes do we need to make?
Well, we have to change first the dynamics. So the curriculum within most of the medical schools has not changed in over 50 years. And why is that? Because the licensing medical exam has not changed in over 50 years. And the schools, in order to maintain their accreditation, have to teach to the test. If your graduates do not pass the licensing medical exam, your school goes into probation, is in jeopardy. So that stalls any innovation, any creativity. We're not teaching doctors how to engage with their patients. And we've seen this. So there's a high fail rate in the second part of the boards, which is an audio part of the exam, where it's a verbal. And you have to assess a patient and then communicate the diagnosis and the treatments. Well, the problem is we're dealing with a video generation of young men and women whose interpersonal skills are lacking.
The curriculum has to match the demands.
And the current environment.
Are changing in that way.
Well, but it's hard. They're talking about it. But at the end of the day, until the licensing medical exam changes, they can't change.
Mike Maron has given us a lot to think about, particularly as we move into the second portion of the Think Tank program today with this panel. Mike is the president and CEO of Holy Name Medical Center. Thank you, my friend.
Thank you, Steve.
Well done.
Appreciate it.
This is Think Tank. I'm Steve Adubato. That's Mike, and we'll be right back.
To see more Think Tank with Steve Adubato programs and to listen to Think Tank with Steve Adubato, the podcast, visit us online at steveadubato.org. If you would like to express an opinion, email us at info@caucusnj.org. Find us on Facebook at facebook.com/Steve Adubato, Ph.D. And follow us on Twitter at Steve Adubato.
Welcome back to Think Tank. I'm Steve Adubato. We continue the conversation on the future of healthcare. We're pleased to be joined once again by Dr. Shereef Elnahal, who is the commissioner of the New Jersey Department of Health. Amy Perry joins us for the first time, is the CEO of the hospital division at Atlantic Health System. And finally, Dr. Stephen Crystal is the Board of Governors professor at Rutgers University, who's been with us many times talking about healthcare. So here's the thing. Right now, is there more affordability and accessibility than there was 5 years ago in the healthcare system in New Jersey and in the nation, Doctor?
Well, there's no question about that, Steve. And the biggest legacy we've seen is from the Affordable Care Act. That was implemented in earnest.
March of 2010?
Yeah, passed in 2010, really took effect, especially with Medicaid expansion, starting in 2014, 2015. And we've seen over 800,000 people covered with insurance in New Jersey that were previously uninsured. The uninsurance rate dropped to an all-time low a couple of years ago. Unfortunately, though, because of the continued attacks on the Affordable Care Act from Washington, we're starting to see the uninsured rate start to creep back up again. And that's concerning, which is, again, why the Murphy administration has doubled down on making those protections remain right here in New Jersey.
Dr. Crystal, would it be a bad thing if the Affordable Care Act were abolished by the courts?
Not bad, disastrous.
Because?
Because it's embedded in so much of the system that we now have, and because it has provided access to such a large population of people who previously were not eligible either for Medicaid or for private insurance. The Affordable Care Act made pre-existing conditions, the access to insurance without pre-existing conditions, a reality, and it's only the different parts of that that make that possible.
Let me ask you, Amy Perry, for those who argue, hey, Medicare for all, it's going to be an issue in the 2020 presidential race, you say?
I say there's probably other solutions that will achieve the same kinds of things, which is providing reimbursement, access, insurance to everyone, that are probably not as controversial or difficult to get through.
Let's do this. We talked earlier with Mike Maron about the whole question of technology and how the future of healthcare is being shaped by technology in so many ways. On the question of accessibility, I was just saying, okay, you take a picture. It's great if you can video connect to a physician or a healthcare professional. But if you take a picture of a rash, I just kept saying, you take a picture of a rash. You're laughing, right, Amy? Because you take a picture of a rash, you send it to a doctor. You're able to talk to that doctor. He or she says, wait a minute, I think it's this, and you should put this on it. I'm going to write a script for you. Good idea or bad idea?
I think it's a great idea. I think we need to empower our consumers with every piece of technology and talent we can. People are searching for answers now. People want to have more control over their health care. That's a really good thing. That might be due in part to the fact that people are more responsible for higher deductibles. There's a lot more financial risk for people. So we need to empower people with education, information, apps, digital call centers, websites, whatever we can.
That empowers people, but I always wonder about the quality control issue. You say, Doctor?
Well, you know, I actually agree with Amy. I think overall, There's a lot that can be done through telehealth and through the technology that we've already used for years to communicate with our loved ones and preserve relationships over thousands of miles. I do believe the patient-doctor, the clinician-patient relationship can be preserved through this technology if it's implemented in the right way. And all of that has to be co-designed with our patients, with their caregivers.
Dr. Crystal has some concerns.
The technology, the sweep of technology has definitely had some downsides. We haven't seen, for example, the widespread adoption of electronic medical records yet improve our outcomes. And we have a problem with outcomes. As a matter of fact, we've now had, for a variety of reasons, not necessarily connected to that, the third year in a row of declining life expectancy in the United States.
What are the implications of that?
The implications of that are that we need to start identifying people who are at high risk from causes of death that are increasing. Opioid overdoses, for example, 3,000 drug overdoses in New Jersey, and the larger problem of people who are falling off the tracks, having behavioral health challenges of all sorts.
Let's do this. By the way, this is Think Tank. I'm Steve Adubato. We're talking about the future of healthcare. One of the many issues we're going to be tackling, a whole range of very complex but important issues that we think and we know you care deeply about, and that's why we're talking about it. How about this? Preparing physicians of the future for the future medical education. You were in medical school.
I was.
Not too long ago.
Yes.
To what degree did medical school prepare you to be the physician you needed to be in this, dare I say, marketplace? I hate calling it that.
Well, Steve, I learned the fundamentals of diagnosis and treatment, and that's the core foundation of what every physician should know when they graduate. The world is rapidly evolving, not only technology and the surrounding infrastructure that patients are more familiar with, that physicians need to be more familiar with, but also the social needs. I mean, the opioid epidemic has exploded over the last several years. I got one course on addiction treatment during my medical school years, and now Rutgers is actually leading the country by making sure that all of their medical students have the certification from the federal government to treat addiction. So because our public health problems of today are rapidly evolving, it's never going to be enough just in medical school. We have to learn throughout our careers.
And there are a range of there are new medical schools that did not exist before. I know Seton Hall has one with Hackensack Meridian. I know there's one down in South Jersey. Rowan's involved in one as well. Rutgers has it. But you've talked about this as well, and you've said that there's an approach to preparing doctors that should be different.
Yes, I agree.
What is rotation piece? Talk about that.
Right. So at Atlantic Health, we have a regional campus of Jefferson.
By the way, before you go any further, let me disclose this. Atlantic Health is an underwriter of our programming. Go ahead.
I'm glad to hear that.
Okay, but I just needed to disclose that. Go ahead.
Good for you. So we have an undergraduate campus that is affiliated with Jefferson University, and last year
Jefferson's where?
In Philadelphia.
Got it.
And last year we started something called a longitudinal integrated curriculum. This is a very different way to approach medical undergraduate education, in that instead of a rotation, instead of 4 weeks on OB and 4 weeks in surgery and 4 weeks in medicine, we run those tracks throughout the year so that our interns can develop a patient-physician relationship. To your point, it's like, how do we put the humanity back into this? It's not just about learning the skill, the technical aspects. We want to have this be about the patient at the center and giving our students enough time to actually have a relationship with our patients. It's really fantastic.
Dr. Crystal, you question the degree to which a physician can truly have that relationship no matter what the training is because of the environment.
The relationship is super important. We need to start taking away some of the structural features that
Name them.
Electronic medical records, we need to figure out how to manage them well. Compensation for primary care.
Excuse me, that gets in the way of the relationship between doctors and patients?
Spending half the time on the looking at the keyboard, both doctors and patients will say this, that it has taken time away.
You're making it sound like technology is getting in the way of human interaction.
It definitely has that potential. It's hard to manage. It has upside potential. The reason, one of the many reasons this is so important, is it's a dance between the physician and the patient, and a lot of the health improvement that you get from that is not just technical, it's relational. It's hard for patients to change, and a lot of the bad outcomes that we have are related to behavior. So it is in the doctor-patient relationship that you collaboratively need to work together to solve the problem, build trust. Without that, you can write all the scripts you want. Half the time, people won't take them. And one of the things that we need to change medical education, instead of learning hospital medicine, exclusively learning specialty medicine, learning how to become an effective primary care doctor.
And that's evolving over time, but you argue not fast enough.
Not fast enough.
Let me ask you this. Dr. Elnahal, you are the head of the Department of Health, and you see these numbers more than anyone else. Infant mortality, higher in the African-American community. Women who give birth, the death rate, much higher in the African-American community. Why? And as it relates to the future of healthcare, what are we doing and should we be doing?
Well, Steve, I'll just start by saying it's tragic, it's shameful, and it's a product of institutional racism. And I'm part of an administration that is not afraid to say that, because if you don't recognize the root cause, you won't be able to address it in a fundamental way. And so 3 to 4 times the rate of infant mortality in black infants versus the general population, 4 to 5 times the rate for black mothers in the first 42 days after birth passing away versus the general population. Completely inexcusable and preventable.
National crisis?
I believe it's a national crisis.
Sorry for interrupting. Is it acknowledged to be a national crisis to the degree that the United States Congress is even talking about it? Because maybe I missed it.
They are talking about it. In fact, Black Maternal Health Week was just last week. There is a caucus that is devoted to this in the House of Representatives now, and they're already coming up with a lot of policy ideas, aggregating research, aggregating efforts at the state level. For example, in New Jersey, First Lady Tammy Murphy is leading the way across several agencies, not just health and human services, but everything else.
But there's a national movement here. Do you sense the national movement here?
I do. I think that patient safety is really a very, very important and rising interest. I think that we have a heightened awareness of the dangers of not taking care of people preventively. I do think we're all looking outward. We at Atlantic Health are working on a community outreach hubs. How do we get to patients earlier, especially in their maternity cycle, make sure that people have education and the tools they need. I think that that's going on across the country.
To that point,
real quick, because I'm going to go back to you, Stephen.
Yeah.
No, go ahead, make your point.
To that point, I wanted to say, when we talk about the future of healthcare, it's easy to default to discussions around technology, discussions around data. That's what immediately comes to mind. But what also has to be part of the future of healthcare discussion is how we're changing how we engage patients fundamentally, not just within the walls of a clinic or within the walls of a hospital, but knowing that because of the legacy of institutional racism and social determinants of health.
I was a social determinants of health, social impact. That is different than by understanding issues of not being able to get where you need to go because of transportation, lack of transportation, poverty, crime, education. They are social determinants of health. And what does that have to do with the future of healthcare?
Oh, absolutely. Because as Amy was mentioning, meeting people where they are has to have an operational strategy behind it. So, for example, our public health department has trained 72 community health workers, specifically targeting communities of color in our urban areas. We're sending out, many of whom are black women themselves, to women who are thinking about becoming pregnant, who are already are pregnant, connecting them with doula care, connecting them with prenatal care, Healthy Start, home visiting. These are programs that are, for the first time, reaching out into communities of color.
It's changing the future of healthcare. Dr. Kristen, when you hear that.
An example, there's a lot of conversation about the social determinants of health. How the healthcare system can actually engage with that is a little bit harder.
Why?
Because what we have is a medical care system, not a healthcare system.
We treat you when you're sick?
Yes, but here's an example. Individuals who have severe health problems that are exacerbated by homelessness, whether it's homeless mentally ill people, homeless substance abuse people. Historically, the thinking was we need to resolve their mental health, their behavioral health problems before we can house them. What we've learned in city after city, state after state, is housing first. You get somebody housed with support, with housing with supports built in, you start to become then able to address those healthcare needs. So you could replicate that in a lot of other social problems that people have.
Got a minute left. I hate when I do this question, I have to ask anyway. How optimistic are you about the future of our healthcare system, improving it in terms of affordability, accessibility, and preparing our doctors? How confident are you?
I actually couldn't be more optimistic.
Really?
100% optimistic. Because I feel like I'm surrounded, at least in my environment, with a bunch of innovative thinkers, with people that are leaning into how do we change, instead of fee for service, fee for value, how do we lean in, how do we change the face, how do we lead in this space? I'm 100% confident we're going to get there.
Optimistic, confident?
Very optimistic as well. And that's because I think we're finally starting to frame the problems clearly and in a comprehensive way across different stakeholders and across the political spectrum. Everyone agrees about the problems we need to solve, and I think we're very well poised to begin doing it.
Steve?
It will be
2 seconds.
A political struggle, a social struggle for the rest of our lives. There are, on the positive side, we're getting better coverage, but there are system transformations that we need to work on for the foreseeable future.
Well, let me say this. You have helped the conversation greatly, and I want to thank all of you. That is it for this edition. For everyone at Think Tank, I'm Steve Adubato. Thank you so much for watching, but most importantly, make sure that you think for yourself. See you next time.
Think Tank with Steve Adubato has been a production of the Caucus Educational Corporation, celebrating over 30 years of broadcast excellence. Funding for this edition of Think Tank with Steve Adubato has been provided by New Jersey Sharing Network, NJM Insurance Group, the Russell Berry Foundation, Johnson & Johnson, the Healthcare Foundation of New Jersey, New Jersey Resources, and by Kessler Foundation. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area.
Did you know LGBTQ youth are 3 times more likely to attempt suicide than their straight peers? All youth deserve to feel safe. All youth deserve to feel their life is worth living. Bullying contributes significantly to how LGBTQ youth feel about themselves. A rainbow's colors makes its beauty, and our diversity makes our communities vibrant. Bullying lesbian, gay, bisexual, transgender, and queer youth dims your light. Be an upstander and stop bullying.